Hello, everyone. Thanks so much for allowing me to present my work today. Today, I'm going to be talking a little bit about emotions that may be predictors of colonoscopy avoidance, and I'm going to be talking a lot about disgust. So if you're eating a snack, I'm sorry. Um, so today I'll talk about some of the ways that we typically model our interventions around colonoscopy. I'll talk a little bit more about some of these more affective or emotional determinants of colonoscopy decision making. And then I'll present some research about the relation between disgust and colonoscopy and highlight some potential clinical recommendations for encouraging average risk patients to complete colonoscopy screening as recommended. So I am from Brown University in the United States. And in the United States, as with many other countries, colorectal cancer is the third most common cancer for both women and men. And recently, recommendations have changed from getting a colonoscopy between the ages of 50 and 75 to starting at 45 in the US. And regardless, I mean, I think this is going to be an even bigger challenge because right now we know that colonoscopy coverage is low, and it's especially low for African Americans and other medically underserved populations. As we all know, late stage diagnosis leads to increased mortality. And so it's critically important that we're able to get more people screened for colorectal cancer as it's so highly preventable with early detection. And that also early detection can help for all, can help increase health equity around colorectal cancer burden. So, and not to get too highly theoretical with my presentation, but I just wanted to highlight that typically when we think about some of these very classical behavior change theories, they involve this idea of balancing cognition. So, what is the cost versus the benefit? Some of this expected utility weighing, benefits versus barriers is a big piece of a lot of different intervention research around prevention behavior, and especially around colonoscopy, and then how self-efficacious or how confident people are, which is not wrong. These cognitions are really important. And I think they determine some of the valence in how people think about a behavior. Especially, is this behavior something that I should do? But I think that affect our emotions can sometimes act as a signal to drive the behavior. So that when people, if they've already decided cognitively that this is something they should do, an emotion, such as we see a lot in the literature, such as cancer fear or cancer worry, can work to kind of signal and drive that behavior. So even though we know this, we tend to model a lot of our colonoscopy related interventions around these cognitions, and we still see low colonoscopy coverage in the United States. So this is just some work that my lab and I did a few years ago, looking at 500 African Americans who had never been screened for colorectal cancer, either with colonoscopy or FIT. And this is some kind of like baseline before our intervention, just looking at some different cognitive and affective factors that were predictive of colonoscopy screening intentions in this population before we actually did our intervention. And we found what we expected to see. We saw that all of these benefits, barriers, efficacy knowledge, risk, all of these different things were predictive of colonoscopy intentions in the directions that we thought they would be. And we threw some affective determinants in there just to kind of take a look and see what would happen. And we saw that both positive affective associations and being afraid of getting a cancer diagnosis were also predictive of colonoscopy intentions. So we thought, all right, well, we know that these are positive affective associations with the colonoscopy procedure. So we thought, we know that globally positive affective associations are related to colonoscopy intentions, but we thought maybe it would be fun to look at which ones. So we looked at all of the positive and negative in affective associations with colonoscopy singly, just as single items predicting colonoscopy intentions. So the question was in our survey, when you think about getting a colonoscopy, how much of that emotion do you feel? So when you think about getting a colonoscopy, how happy do you feel? How angry do you feel, etc.? And actually, my first thought when looking at this was, I wish that this was a qualitative study, because I would love to interview the folks that are delighted when they think of getting a colonoscopy and find out a little bit more about that. But I also thought, all right, well, negative affective associations globally were not predictive of colonoscopy intentions in this population, but some of them, when we looked at single items, were. And it looks like disgust, and embarrassment and fear predicted colonoscopy intentions in the direction that we would think that they would. And so we started thinking, all right, well, disgust, that's kind of interesting. And it sort of makes sense, right? Like disgust is a negative emotion signaling withdrawal from a health threat. So biologically, it's there to protect us. If we smell something stinky, we're probably, and it disgusts us, we're probably not going to eat it. So discuss regarding contamination, but also this integrity of the body and the bodily envelope. So like most likely we tend to avoid sticking things in our body that we shouldn't. And both the prep procedure and the colonoscopy procedure involve both of these kind of disgust elicitors. So, the prep procedure has a lot of different things that people might feel are disgusting, and colonoscopy, like it does involve inserting something into the bodily envelope. And so we know that in other research, these types of disgust have been related to avoidance and delayed decision making, and in colonoscopy in particular. So we were interested more in what types of disgust were most related to colonoscopy avoidance and how. And looking into this a lot more, we found there's a lot of different types of disgust. There's this colonoscopy associated disgust, which is what we briefly measured in our other study. There's state disgust. So this is, it's feeling disgusted in the moment. And in looking at more literature, there's some fascinating work where people prime affective or state disgust by like spraying like a bad smelling smell in a room and then asking a battery of questions, or like bringing participants to a garbage can where there's what looks like a used condom. I thought it was fascinating. Then these are sort of the more situational versions of disgust. Then we have these like trait disgust, which is really like a personality piece. So like as a person, like how likely are you to be disgusted? And then disgust sensitivity, which is also sort of a dispositional, how sensitive are you to disgust? So we thought, let's look at all of these on colonoscopy avoidance and then kind of see how they work together. So this was our study. We looked at sort of main effects of all 4 types of colonoscopy or of disgust, both situational and dispositional. And we wanted to see how they were associated with intentions to complete the preparation procedure, intentions to complete colonoscopy, and intentions to talk to a provider about getting a colonoscopy. And then we wanted to kind of see how these dispositional forms interact with these more situational forms to determine colonoscopy decision-making. So this was just an exploratory study. We recruited 300 participants from Amazon Mechanical Turk. We had all of our participants read information about the full colonoscopy procedure, including the prep procedure, and then afterwards complete a survey where we kind of measured each of these different disgust measures, and then we also measured their behavioral intentions to talk to a provider, to complete the prep procedure, and to complete the colonoscopy procedure. And so we looked at the main effects of each form of disgust on each of these different intentions singly. And then we looked at an interaction between these more situational forms of disgust and the dispositional forms, and how they were related to colonoscopy intentions. So sorry, this is 296 people who have never had a colonoscopy. So in our univariable results, we saw that for each intention, the situational forms of disgust, but not these dispositional, not these personality traits, but the sort of in the moment forms of disgust predicted avoiding colonoscopy, at least in avoiding colonoscopy intentions or lower colonoscopy intentions, which I think is a great finding, because we can change the situation more than we can change people's personalities. So I thought that was interesting and definitely had some clinical relevance. And then when we looked at the interaction, so then we decided, all right, well, even though these kind of more dispositional forms of disgust, disgust sensitivity and trait disgust, even though they weren't predictive of colonoscopy intentions on their own, we wanted to see how they might interact with these more situational forms of disgust. So we found that there was a significant interaction in both intentions to talk to a doctor about. Sorry, let me just back up for a minute. I'm so sorry. I feel like I am confused by these charts a little bit because they are counterintuitive. So on the relation between state disgust and intentions to talk to a provider, we saw significant interactions for both disgust sensitivity and trait disgust. And as I mentioned before, you'll see that the results are counterintuitive because when there's low levels of disgust sensitivity or trait disgust, they're more strongly associated with screening intentions as compared to those with higher levels of dispositional disgust. So in other words, highly disgust sensitive or dispositionally sensitive people have intentions that change less with increasing state disgust than individuals who are less dispositionally disgusted, which is a little bit different than what I had expected to see. But I think as this is we're just sort of exploring how different forms of disgust may interact with each other to predict colonoscopy avoidance or to predict colonoscopy intentions. I think that maybe we may need to add some other things to our model. So we saw that these greater levels of situational disgust, so disgust associated with the colonoscopy procedure in general, or feeling disgusted in the moment, were associated with greater intentions. So that's, as I mentioned before, that's great news, because that might mean that disgust may have to do with the procedures and the environment that people are in than the actual people. And so again, those are things that we can much more easily intervene on and change than people's personalities. And theoretically, it may mean that the mechanism by which state disgust influences the colonoscopy may relate more to generalized disgust tendencies. So the environment that people are in may interact with people's personality to influence colonoscopy intentions. And so I guess a takeaway are what I took away from this work, and in looking at some of my other work around affect and colonoscopy decision making, is that the decision making processes underlying disgust experiences, we do need to know these cognitions. We do need to know what people know about colonoscopy and their own beliefs about colonoscopy, but it's also the degree with which one associates disgust with the actual colonoscopy procedure and their situation and experiences of disgust when thinking about the procedure are also important. And one piece of that is in talking about the procedure. And I think that's important to know, because providers if they're going to refer somebody for a colonoscopy or give someone a colonoscopy, they're going to need to talk through all of these different steps, including the prep procedure and the actual colonoscopy. So the clinical implications of this work, and again, it's an MTurk study and it's pilot work, and so I think we need to do a little bit more. But that maybe disgust associated with colonoscopy could be minimized using some kind of affect regulation technique. So talking to people and not letting them become so dysregulated or upset about colonoscopy, especially when they think about disgust. And then providers could also prepare patients for the disgust eliciting aspects of the procedure first. So tell them everything that's going to happen in prep and in the colonoscopy. but then take the focus off of the actual procedure and talk about some more positive affective associations, which we saw in our earlier work are associated with getting a colonoscopy. And one of these things could be, the relief gained by knowing the personal risk of colorectal cancer is lower. And we see that in work with people who have already had a colonoscopy before, that this positive affective association, this idea of relief or satisfaction in knowing, can sometimes help do the next colonoscopy and be on time and adherent to that procedure. Also, the state disgust may have a lot to do with the environment. So reducing situational disgust in the clinical setting could increase chances of prep and colonoscopy completion, making it an environment that makes people feel comfortable and that primes them for more positive affect. There were definitely some limitations in this work. It was a cross-sectional self-report study. The mean age of participants was 35 years. So our inclusion criteria was anybody ages 18 and older. So not everybody in our study was age eligible for colonoscopy. And racial ethnic representation was relatively weak. 75% of our study participants were white but we think that there's more to the story of colonoscopy intentions than cognitions alone. And so in conclusion, I would encourage us all to kind of think more about affect, many different types of affect when we are planning colonoscopy interventions. And then, we do need to do additional work. So to see whether decreasing disgust affectively associated with colonoscopy or influencing the environment to minimize state disgust increases screening behavior. So I think the next steps for this work would be to pilot some interventions and see how they do. And thank you all so much for letting me talk about my study. And I want to thank my mentors, Mark Kivanemi and Deborah Irwin at Roswell Park Comprehensive Cancer Center, where I did my PhD training, and then also my colleague Maria Keller for helping me do this study and present this work.
Thank you so much, Lynne. That was an excellent talk. And it's one of the great shames about these remote webinars that we can't applaud you for your excellent, for your wonderful talk. But yes, really, really interesting work. And we have a couple of questions, so I'm not going to take chair's privilege, but just get straight to it. We have a question from Leo van Rossum, and he asked, how might this situational disgust be influenced by first doing a FIT? So in some programs, people will, the entryway into a colonoscopy would be to complete a fecal immunochemical test. How might this influence situational disgust?
Yes, well, I mean, I think depending who you are, I think FIT is a wonderful first step for average risk individuals to get screened for colorectal cancer, especially because they can do it at home. It reduces so many of the barriers that we know are inherent in colorectal cancer screening, especially among more medically underserved populations. But certainly having to take a sample of your own stool from a toilet could feel very disgusting in that moment. So I think that it would be really interesting to look at this with FIT and see what kind of differences we see.
Great. And one question that was also on my mind is, what are your ideas about interventions to put this theory into practice?
Yeah, great question. Well, I think I've been seeing a lot of recent work around narrative interventions to get people to get a colonoscopy. So the idea is that instead of just doing these very didactic focus, here are the facts, you should get a colonoscopy, it's listening to somebody's story about their experience getting a colonoscopy. So I think it may be interesting to take videos of people sharing their story about getting a colonoscopy and have them sort of discuss both any kind of disgust reactions that they've had, but then also talk a little bit about the positive experience they have seen. So I think an interesting idea to test, I think, is to tell people what it's going to be like, and expose how disgusting it's going to be, but then talk to them about the positive affect as a next step to sort of get away from that like situational disgust.